Okay, now so we come to the next part of the topic, and that is taking care of different grafts which are there. So Dr. Vikas has already taken us through the journey of different types of grafts. Let us now revise how they would look like. So what I want you to gather from this talk is what you must know is what is the normal, what are the different types of normal, and how do you define complications or how do you recognize them so that we are able to manage them effectively and timely. So as we all know, DSEK or DSAEK, that is desmate stripping endothelial keratoplasty or automated endothelial keratoplasty, is the new in thing, and this does not require a full thickness penetrating graft. What we do is just simply transplant a little bit of posterior stroma along with the desmase endothelium complex into the host eye, and then the entire graft starts working, and the new endothelium can give clarity to the host cornea. This is the clinical picture of how a typical DSEK looks post-operatively. So what we have to realize here is on the slit lamp picture, we'll be able to see a posterior lenticule there attached to the posterior host surface. And initial post-operative period, you will be seeing a little thicker lenticule, as in how the graft starts working and gets active. The thickness of the lenticule also starts to decrease, and the compactness of the cornea is better. Now this is a typical case of a graft detachment. As you can see, the anterior part is the slit lamp is showing the host cornea, and there is the posterior lenticule which is detached, and there's a fluid space in between the two slit images that you see. So this is a typical graft detachment. So can this be managed? How often or how soon should this be managed? As soon as you see this should be managed immediately. This is done by pushing in an air bubble inside, and this is the OCT picture. And post-operatively, if the detachment is managed well, the graft might be able to work again, and the endothelium is then able to clear the cornea again. So the other complications with DSEK grafts could be infections. So there could be superficial infections, and the most dreaded ones are the ones in which the infection happens between the lenticule and the posterior surface of the host cornea. That is the place where no antibiotics are able to reach, and that would require a full thickness penetrating therapeutic keratoplasty. So here we were able to identify this infection. It was superficial, and this was a case of a known HSV keratitis. And so we started the patient on oral as well as topical antivirals, and this started decreasing, and as soon as the defect was decreasing in size, we started off the steroids again, and so the graft was salvaged. Now, this is a typical pre-operative picture of a pseudophakic bullous keratopathy, which was happening due to a mobile anterior fixated iris claw lens, and it was doing well post-DSEK. As you can see, the cornea has cleared up. But then after 2 months, the patient came back with drop in vision and haziness. And as you can see here, there is typical, if you see there very carefully, the slit lamp is showing mild edema inferiorly, and there is presence of KPs over there. So what I'm trying to show over here is the rejections in PK are more pronounced, and the DSEK rejections are very subtle. So this is because the amount of tissue that has been transferred into the new host is lesser in DSEK, and so they are the signs which are there are subtle, and you have to pick them up and then manage them accordingly. The treatment remains the same, that we have to, if treated within time, within 72 hours, you have to give them intravenous methylprednisolone IV, and you have to start them on topical steroids. Now this is the OCT picture wherein the DSEK graft is showing few KPs over there. Sometimes you might be able to see a graft rejection line typical to the PK grafts like the Cordadose line, but this is not very common. And areas we have to specifically look for the rejection is areas of PAS or peripheral anterior synechiae, wherein the iris is providing the vessels to the graft, and then there is the area of rejection that is happening, or the edema that is setting up. So the next came DMEK, and that is the desmase membrane endothelial keratoplasty, wherein the stromal component has been eliminated and only the desmase endothelium complex has been transplanted into the eye. The OCT picture looks beautiful. It's almost like a normal cornea. This is the pristine, clear looking DMEK graft with a clear compact cornea. Again, there could be a detachment over here, as the posterior lenticule, which is there, can get detached either locally, as seen here inferiorly. If you can see there, there is a small area of detachment if you are able to pick it up. Here is another central detachment, and again, rebubbling is the procedure of choice and has to be done immediately, and then the patient has to be managed well. Graft rejection again is a problem in DMEK, and we have to again look for any signs of edema in the graft as well as KPs or anterior chamber reaction. This again might be even more subtler than the DSEK grafts. So again, they have to be managed with intensive steroid therapy. And this was done well, and then the graft maintained its clarity. So this was the DM OCT, wherein the single KP is also seen sometimes. So next, coming over to the anterior lamellar keratoplasty, or the DALK. This is the graft wherein only the anterior and mid stroma is transplanted. This has its set of suture problems, but does not have the endothelial rejection patterns. So stroma is still there, so there could be rejections. And this, if you see here again, there is inferior edema and the stroma is thickened. And if you carefully look, at the 12 o'clock site, there is a loose suture. So these suture problems can lead to rejections. So these have to be taken care of. So here again, the edema resolved. And this is another stromal rejection after DALK, which was managed. Suture problems, not only loose sutures, but also tight sutures could lead to problems and cheese wiring and collection of infiltrates. So the next type of keratoplasty that we might come across would be the artificial cornea, or the keratoprosthesis. Short form is the KPRO. This is the normal picture which you'll see. There might be a tarsorrhaphy present. It has to be a BCL which you will see, and BCL is the bandage contact lens. You have to remove that, and then you have to do the fluorescein staining for this case, and the site of leaks or anything has to be identified. If you see through the cylinder of this, you will be able to see the disc, and then digitally you have to measure the intraocular pressure. So what can look wrong here is that the carrier graft for the KPRO has given away, it's melted, and the backplate of the KPRO is now extruded. So this will be another emergency. And if you see over here, there's an infiltrate around the ring of the cylinder. And if you stain them, then there is this defect which is very evident. When this is referred, then we definitely do the scrapings, and we try and prevent the infection from going down further. Otherwise, this will lead to endophthalmitis or the vitreous involvement as seen in this picture. This is very difficult to salvage now. Other types of grafts are the patch grafts, which you may come across. These are small tiny grafts. They have basically been done for tectonic purposes, and they also come with their set of suture problems and different infections also might be there. So you have to manage them accordingly. So I hope by the end of this, you know what are the different normals and how do you differentiate from the different abnormals. So the next we will come to taking up important clinical discussions over here, and I invite the panel to actively participate here. So whatever points we have discussed up till now, we will just take you through clinical cases and then listen to what all can be done.
So while Purvasha is getting the next thing fixed, I'd like to ask the opinion of my co-panelists about what are the certain points that you specifically see when you select a patient for a keratoplasty? Because like what I had initially highlighted in my talk is that the prognosis of the graft will have a very strong correlation to what indication for which the graft was performed. So when we select a patient for a keratoplasty, what are the things or the important things that you should look before you take up the patient for the surgery?
Basically what I would say is whether patient has, as you have mentioned in your talk, that we need to see whether we are doing a graft for a low risk patient or for the high risk patient, because the outcome depends a lot on that. So like in high risk patients, we need to see whether there are any surface problems. If there are any surface problems, we need to deal with that before we take the patient for the graft. Like if there is any ectropion, entropion, if there is some dryness or some things like that. Again, even if with the vascularization, I guess even trying all this cauterizing the main feeding vessel is an important factor before, it's like, preparatory things for your graft success before you actually do the graft. Even nowadays, there are studies where they have had a pretty decent amount of success with the anti-VEGF drops. So these all things can be done when there is a lot of vascularization. And the most important thing again is the post-op immunosuppression, which will be much more aggressive in cases of high-risk grafts. Again, counseling is very important in such patients, that what a patient is expecting should be very similar to what we are expecting, or we need to tell them that okay, this can be the outcome. Failures can be little more. Chances of failures can be little more in your cases.
Thank you.
Thank you so much, Sushmita. And let's come now to the importance of compliance and follow-up in these cases. I think we just don't have enough words to stress upon the importance of compliance in these cases, or any graft for that matter. The major issues which come up are in the drug regimen, the hygiene, the protection, and during follow-up. So drug regimen, if you prescribe them too many drops too many times, they come over and say, खूपच त्रास देते तुम्ही मला, इतकी सगळी किती वेळा टाकायची. Or hygiene, the patient comes and tells you, oh my god doctor, do I use wet wipes or do I have to use tissues? Please tell me which face wash to use. And for protection, they will come and ask you, ओए बड़ा औखा है काला चश्मा लगाना तो. Or for follow up, they will tell you, दिवाली का मौसम चल रहा है, अभी तो रिजर्वेशन नहीं मिल रहा है साहब जी, कैसे आए. So all these things have to be dealt with in their own way. So I would like to take the opinion of the panelists here. Dr. Sheetal, how do you make sure that the drug regimen is complied with?
Yeah, very aptly said, Purvasha, that too many drops create a lot of confusion for the patients, but then still in our graft, the antibiotics in the initial period is important, and that is the reason again when it is not required, if any drop is not required, it should be stopped. Like antibiotics, after 3 or 4 weeks maximum, there is no role of antibiotics in keratoplasties. Second, steroid is very, very important. So we need to, at each and every visit, we need to ask patient actually to show the drops, what all they are putting it, to examine the drops, the drop bottle, so we come to know the hygiene, whether they are maintaining the drops properly or not. Second, for the prednisolone acetate drops, these are suspension drops, so we need to always tell the patient that you need to shake it before you actually use it. Otherwise, they just put the drop and it may not work so well. Again, ask them that how many times they put it, who puts it. So all these things are very important to see the compliance of the patient. And rest, only important drops give. Just don't give too much of masala, because that may not work. Lesser the drops, better.
Exactly. So how, Dr. Sushmita, how would you talk about hygiene to the patient and protection of the eyes?
Yeah, so hygiene is extremely important, and like I said, in my practice, I think the care of the graft starts even before I have done the graft. So I pay a very, very huge emphasis on selection of the patient, and anybody I feel may not be able to take care of the graft, I explain that it's best avoided unless it's bilateral blind.
Right.
So as far as hygiene is concerned, like I think Sheetal had told in her talk about head bath and how it can be done sitting
very
there
beautifully
in the thing, and regarding how other stuff like swimming and other activities, how we can restrict those things. And regarding cleaning, of course, I give a particular a care regimen to the patient as to how whether they can boil water and boil some cotton in that and and then cool it and then use it to remove all the, especially it's the drug, very often it is the drug like the natamycin or the prednisolone which all get stuck to the eyelashes, and those needs to be very nicely cleaned up, because sometimes the patients are so scared they don't want to venture around the eye and do anything. They just don't want to touch the eye, so but then that is important that they don't do any major intervention, but then they should at the same time maintain cleanliness, and also a general discussion about the hygiene and things like that, and of compliance in general, the need for follow-up, need for proper drugs has to be talked to the patient even before we do the surgery. So those points has to be told way before the surgery. If the patient is mentally prepared, the family is mentally prepared, then only go ahead with the surgery.
That's true. Okay. So follow-up, Dr. Charuta, how do you ensure?
No, I agree with what Dr. Sushmita also touched upon and said, stress upon, is that our chance to tell the patient what is required of him to do is before the surgery. Once he presents to us saying that, oh, look, I want you to do the surgery, that is our chance to tell them that you have to have a follow-up of lifelong. You have to be able to present to us. We have to assess whether the patient has access to our care at the right time. We have to be available to them at the right time. And the appropriate time of counseling them, that they need to come, they need to use the drops, and they need to follow up at the time as per our schedules is before surgery. That is how I manage my patients. And then, of course, as is required, the follow-ups may increase or decrease. That would be the best.
I speak to my patient while I'm operating also, provided he's not under jail. So the most important thing here that we have to take care of is the RSVP, or the redness, sensitivity to light, vision drop and pain. This RSVP has to be hammered into the heads of all our patients. If they have any of these symptoms, they just have to immediately come back to you and report to you, irrespective of what the date of next follow-up was, right? So otherwise, this is what we land up with, and a beautiful graft ends up like this, and or this, or follow-up issues like this with such sutures and poor condition of the graft. So sometimes they give issues like it's snowing over there, and this is the WhatsApp photo that I receive. I cannot come, and we desperately try to call them. If they are logistic issues, definitely they also have to travel long distances, and they come with all their bag and baggages. But we have to make sure that the graft is taken care of, right? And there are suture related issues which have been covered earlier. So broken sutures again can be a cause of foreign body sensation. A drop of fluorescein will beautifully demonstrate where exactly is the pathology and how you can help that patient. Even the most advanced of the grafts, femtosecond assisted PKs, also have their suture related problems, and you have to deal with them too. Any little bit of mucin that you see adhering to that suture, immediately you have to take out that suture. So how do I do it? We just have our best friend, povidone iodine 5%, that is the betadine eye drops, and a 26 gauge bent needle, and sterile forceps, and a piece of sterile gauze. This is all we need for suture removal on the slit lamp. Before that, one or two drops of paracaine have to go in, and after that the betadine stays there for at least 2 minutes. So this is the most important part. You have to give surface time of 2 minutes to betadine to act, and only then start your suture removal. So if you see that the knot is on the host side, on the donor side, then opposite side you have to cut the suture, just flush to the surface of the cornea, and then pull out through that end, and not let the knot cross the graft host junction. That is the most important point, not let the graft host junction be crossed by that knot. So this is a small video wherein you can see that the host, that the knot is on the donor side, and we've cut it from the other side and teased the suture out, and this is now being pulled away with the forceps, and the knot is out without crossing the graft host junction. So this is the way to do it, and don't forget to instill betadine drops again after taking out the suture. So this is the take-home message for suture removal. We also have certain areas of melt just near the sutures which are loose, so you can use tissue adhesives over there after removing the loose sutures and put in a bandage contact lens. Sometimes you come with graft infiltrates and then you have to scrape this area. So make sure you're not scraping the graft host junction, because that would not be a good idea. It's not adhering to the, it's not yet, yeah, it's almost done. So that's the area where you don't want to disturb. So this was usually what we see is GPC or gram-positive cocci and suture-related infections. Sometimes you might be surprised to just put that slide under the microscope in KOH preparation, 10% potassium hydroxide, and you will be seeing so many fungal filaments over there. So this is the antibiotic regimen that we usually use. This is for first-line therapy is empirical, and as and when you have your sensitivity report, this is how we manage our patients. So this is for smear negative cases. Again, we start them on cefazolin and ciprofloxacin. For fungus, we usually give a combination of voriconazole and natamycin, and for candida infections, we add amphotericin B instead of natamycin. So there are referral issues. Always remember that a graft that can be saved in time would be thankful to you throughout its life, and a bad day for the ego is a great day for the soul. So we have issues, we have seen grafts which are referred to us at this point of time, and this is not a very happy state of affairs which we would like. Another patient came to us down from Canada, and she said as soon as she had gotten bilateral keratoplasty done there, and she came back to India, splashed water in her eyes, and then came back, and she had this infiltrate which was being managed by another person somewhere else, and this was the condition after which she was presenting to us after 13 days of having this infection. So early referrals are the key. Press the panic button as soon as you see that something's just not right or is worsening. So pediatric grafts, Dr. Charuta, what do you think, how important is examination for pediatric grafts?
I just want to add to the previous section one thing, that we see some amount of hesitation in removing loose sutures in grafts. So even if the graft is a week old or a month old, there is no point in leaving a loose suture there.
Exactly.
So there's a point that I would just wanted to make.
That will act as a conduit to
it is not going to give any
Right.
tectonic strength, so it has to be out.
So, Dr. Sheetal, what would you like to talk about pediatric graft examination? Do these kids allow you to examine?
The most important thing out here is examination under anesthesia. There cannot be any substitute for this in the pediatric graft. So most of the times we need to do, or at least at maybe certain visits where you need to do the examination under anesthesia is very important, as pediatric grafts are the chances of rejection are more, chances of vascularization is more, chances of the hygiene problem is there, chances of infections are more, loose sutures are more. These grafts heal in a different way than the adults. They heal much faster. The vascularization happens much faster. So examination anesthesia and whatever things we need to do like suture removal and all should be done at the same time.
Right.
There's no substitute for this.
That's true. So we have to stain the with fluorescein and look for the IOP and the fundus and remove any sutures that are there which are loose. We also need stronger cycloplegics and steroids. We need to protect the eyes. There's appropriate suture management. The sutures come out earlier than the sutures in the adults. We have to have a watch on infections, and parental counseling is very important. Amblyopia therapy and rehabilitation is just very important, otherwise we lose the whole essence of grafting. So this was a suture related infiltrate which we managed in a pediatric patient, again to come up with another infiltrate, and then finally right now she's doing well. I'm just anticipating when she will be back with another one. So cataract after PK we have discussed intensively. Just one thing that we want to talk about is a customized smart toric IOL which has come up, and no financial interest here, but we have even managed astigmatism from the range of 7 to 15 diopters here, and with very good results. And PCO again is similar, just PCO after a PK cataract is again can be managed in the same way. You have to YAG it and the steroids continue for a longer period of time. HSV keratitis again is another issue. We have to take care of that and prevent the failing graft. Here was the graft required another DSEK, DSEK non-stripping desmase keratoplasty, and then also an AGV is there over there. So you see that in retroillumination, you see the valve tube over there. So high IOP after PK, you just have to manage medically initially, try and manage without using miotics, without using preferably dorzolamide, which is an endothelium toxic drug, and no prostaglandins. And you mostly have to get down to drainage tubes or cyclocryo later on. Large grafts have their own issues of epithelialization because there's loss of limbus. Then they have glaucoma because the anterior the angle anomalies are there, and then you have to manage rejection because there's a lot of tissue that has been transplanted. So epithelial issues and rejection here. High-risk grafts have been talked about by Sushmita. We have to take care of the neovascularized corneas. If there is SPK present, we increase the dose of lubricants. Might need a bandage contact lens also, maybe a tarsorrhaphy, and these sometimes they have melts, graft melts, which will be managed by amniotic membrane grafting, etc. So moral of the story is always have fluorescein at hand, always measure the IOP, take care of the compliance, always check at each visit, every patient that comes in with a graft, always check their drops, reiterate the need for follow-ups, recognize the abnormal and press the panic button as soon as you feel there's something wrong, and manage and refer while there is still time. So with this revised awareness, I would like to thank my panelists. I would like to thank my my keynote speaker, Dr. Vikas. And the world needs more heroes right now than ever before. And you can be the hero to every graft that you save, right? So you could be the legend to every child that you are able to save the graft of and make her go back to school, and to every adult that you restore her duty or let her resume his or her work. Right, so let us come together to make the difference between success and failure. Thank you so much.
Yeah, I just want to add